His talk is very unique and interesting because this is the style of medicine nowadays, everywhere, is to seek patient satisfaction. If we have teaching course here, my target is your satisfaction, by any means. So when we are in duty with the patient, our target at the end of the day, even if we don't achieve cure or we don't achieve any excellence, but you achieved patient satisfaction, this is your job. This is why I bought for the first time in the International Hemodialysis course this title, Patient-Centered Approach, as a clear in all specialty, and here Dr. Ahmed Abdelwahab will concentrate on CKD and dialysis. Dr. Ahmed. Dr. Ahmed is the lecturer of nephrology, internal medicine and nephrology at Mansoura University Hospital. Dr. Ahmed.
In the name of Allah, the Compassionate and Merciful, at first I would like to thank the organizing committee. Again, it's a pleasure and it's an honor to be introduced by Dr. Hussein Shaisha. He called me a friend and a colleague. I think I'm related than this. Inshallah, we're going to speak about the new approach in managing our patients generally, and we are going to focus on some issues about the chronic kidney disease and hemodialysis. At first, in 2001, the Institute of Medicine have made some changes in the practice of medicine and have put some regulations and some standards. They have set 6 regulations or 6 rules while we are treating our patients. These rules are the equity, the timeliness and effectiveness, efficiency, patient-centeredness, and safety. This should be applied while managing any of our patients. The term patient-centered care appeared in 2001 by the Institute of Medicine to be defined as compassionate and empathetic and responsive to the needs, values, and expressed preferences of each individual patient. And patients should be informed decision makers in their care. They are not just receivers, they are one of the makers of the decision. The patient-centered care should consider the patient as an experiencing individual. He is like a consumer, an experiencing individual, beyond being just an object for a disease. So he is not going to come to me to the dialysis unit as a patient and then he will go home. No, he will share with me the decision and how I'm going to give him the service. This means that the care providers must have an understanding of the patient's context. Another definition was made by Berwick in 2009, who suggested that rather than care providers acting as hosts, we are the hosts, and the patient is our guest. We should be the guests in our patient's life, and they should be the hosts. And he called, or he proposed a new definition that the experience, to the extent the individual patient desires it, of transparency, individualization of the treatment, recognition, respect, and dignity, and the choice in all matters, without exception, which is related to his circumstances, relationships in healthcare. In this review article about the patient-centered care and the opportunity to accomplish the 3 aims, they said that the patients in the disease process should share, rather being parentalized. We are not going to treat these patients as children, and that we are their parents, and we are going to dedicate, we are going to say, you should do this, and you shouldn't do this. This is not the approach. The approach is to share the decision with our patients. And sharing decision making has been called the pinnacle. This is the stem, this is the cornerstone in the patient-centered care. The sharing decision making is defined as a process of communication by which physicians and patients agree on a specific course of action. We are going to meet in the middle ways. They are going to agree on a specific course of action based on the understanding of the patient's preferences and the treatment goals and benefits versus the harms of different treatment approaches. Some definitions should be known. We have the term consumer-centered, person-centered care, personalized care, family-centered care. In fact, in the literature, the person-centered care or consumer-centered care are the same as the patient-centered care. The personalized care is the integrated practice. We have the doctor, we have the patient, we have the family, and they are going all together to share in the decision-making. The family-centered care rose up in the families taking care of some patients who are incapable or unable to leave the hospitals. These patients are going to remain in the hospital for very long periods, and from this, due to this cause, the family-centered approach appeared. The Institute of Medicine have made four levels to achieve the patient-centered care. These four levels are the experience level, and this is at the patient's level. He is going to tell me how my service satisfies him. The second level is the clinical microsystem, and the clinical microsystem involves the hospital or the place he is going to receive the service. The organizational level is going to mix with the clinical system level. They are going to be one, sometimes it's the dialysis unit alone, and sometimes it's the dialysis unit inside a bigger hospital. So everything involved in these two environments is going to be related to this patient-centered approach. And lastly, the environmental level, which could be reached up to the Ministry of Health or to the child support or to a federal government to report about the service he is going to receive and how would he like to receive it. So what about nephrology? In fact, the Renal Physician Association and the American Society of Nephrology in 2012 and 2010 have supported the application of the patient-centered care in nephrology. But what about the real life? Do we do this or not? In fact, however, the available evidence suggests that shared decision-making is currently poorly integrated into the clinical care. We are not integrating our patients. In fact, we tell our patients in most of the occasions that dialysis is a must. The dialysis is the only available line of treatment, and you should choose dialysis. No, this is wrong. We should inform our patient that his options of treatment are the conservative line, the dialysis option, which could be the definitive line of treatment for his life, which could be the only line of treatment for his life, or it could be a bridge. The dialysis could be a bridge or a destination to the final destination of the patient, which is transplantation. And sometimes, when we meet a patient who is going on conservative treatment, this conservative treatment is incapable to control the case. At such a case, we are going to say to our patients, you should go to dialysis. And we are going to offer the different modalities of dialysis. In fact, the patient has the option and the right to choose to start dialysis or even not to start dialysis and to just go to conservative treatment. So, implying something to the patient and to say to him, this is your only choice, is wrong. We are going to give him the options, number one, number two, number three. We are going to say the harms, the benefits, and then we are going to share the decision making with our patients. The practice of the nephrology or the dialysis, in fact, At first, when the dialysis is initiated, depends on what is called the disease approach, disease-centered approach. I mean, we all aim to achieve the standard dialysis care. We aim to achieve a good KT/V. We aim to achieve a good anemia control, a good blood pressure control. This is our aim when we start dialyzing our patients. This is not wrong, but sometimes these regulations or these recommendations does not go in pace or does not meet the needs of our patients. And ironically, when our patient is going to die or the prognosis of our patient is going to be less, we are going to shift from the disease-centered approach to the patient-centered approach, and then we are going to focus on the symptom control and to relieve our patients. So we shift to the patient-centered approach, but we shift lately. We shift lately when our patient is going to die. The patient-centered approach, due to non-integration or unintegration in the clinical systems, had led to some mistakes like this paper, which dedicated the factors associated with suboptimal initiation of dialysis despite of early nephrologist referral. You are going to notice that in the patient-related delays, it constituted about 30% of the cases. This is 1/3 of the etiology for suboptimal start of the dialysis. The 30% of the patients stated that the cause of their delay, they didn't communicate with the physician. They didn't understand what they are going to do. So we need to communicate with our patient. They didn't understand what is dialysis, what is conservative treatment, what is arteriovenous fistula. You need to communicate with your patients. So why do we need this approach? Why it's important to shift from the disease-centered approach to the patient-centered approach? Because we have complex morbidities. You are not going to face a patient with chronic kidney disease alone. He is going to suffer from diabetes, COPD, sometimes chronic liver disease, sometimes respiratory failure, pulmonary hypertension like the previous, ischemic cardiomyopathy, heart failure. So we have multiple comorbidities. And if we try to apply all the guidelines to treat each disease of them separately, we are going to find it so difficult, and we are going to find so many drug interactions, because we are going to try to apply the recommendation or the guidelines for each disease alone. We are treating the disease, not the patient. This is the disease approach. The opposite is to see my patient needs, what is more essential for him, what is more important for him, and then we are going to focus our treatment according to our patient needs. So the complexity of the comorbidities, the multiple geriatric symptoms, the signs and symptoms which are not often due to a single pathophysiologic disorders, the heterogeneity in life expectancy. There is somebody who wants to live much longer, and some other person who just wants to attend the marriage of his daughter. He will tell you that, I just want to do this, and then you can let me go. I'm not going to do dialysis. So the expectations of each one and how we seek to live make us to choose or to divert from the disease approach, centered approach, to the patient-centered approach. The components of the patient-centered approach, it is composed of 8 steps. We have to fulfill these 8 criteria to achieve the patient-centered approach. They are the respect of the patient's values, the information and education of the persons, of the provision, access to the care, the emotional support, the involvement of the family and the friends, the physical comfort, and the coordination of the care. And in order to operationalize and how to make this system effective and working, we have to see the moderators, the patient condition and expectations, which are going to lead to the patient satisfaction, patient clinical outcomes, and organizational outcomes. So these processes, the 8 processes, will depend mainly on the patient condition and expectations to have the outcomes at the end, the satisfaction of the patient, which is the first one, the clinical outcomes, which is important for me as a doctor, and at last the organizational outcomes. They have set 3 aims. To achieve these 8 goals, we have 3 aims. The first was to enhance the efforts to help the patients and their families, to promote the shared decisions, and to tailor the treatment strategies to what matters most to the individual patient. Again, to tailor the treatment according to the desires and to the respect of the patient himself, and sometimes to his family. The evidence, in fact, the evidence is not against the rules of the patient center, but the evidence denotes that in spite of that, doctors are not pushing for the patient-centered care. In this Canadian meta-analysis, they have asked the patient about the 10 most important things that research should seek or should go in to try to reveal in the practice of hemodialysis. They have asked the doctors and they have asked the patients. These are the 10 or the top 10 questions that the patient and the doctors asked that research should focus on this 10 questions. Then what about the research actually? They have searched in the medical literature to find that there are about 4,000 articles, of which only 200 is addressing these 10 topics. From 4,000 articles, only 200 is addressing the 10 most important questions told by the patients. So we are not addressing the patient at all. They have searched in the WHO clinical trials and found about 700, of which only 70, this is 1/10, addressing these questions. And they have found, searched in the National Kidney Research and found about 70 articles, only 15 of them is addressing this 10 top questions. So in spite of being very important for the physician and for the patient, the research is ignoring and is not addressing these important topics. And this is the comment, only about 20% of the clinical research is aiming to address these 10 important questions. Again, another search was done to see the self-management and guideline adoption in, to make the patient orientation about self-management. He is going to plan for himself a plan of treatment. They have found about 77 articles about this in the guideline. They have found that we have to do 3 things. We have to inform the patient and the relatives, we have to activate, we have to collaborate. And when they studied these 77 articles to see if they apply for these 3 items, they found that some articles was informing only, activating only, collaborating no one, informing and activating 14, activating and collaborating 1, informing, activating and collaborating 6. What is important for me is the positive one means that when the patient was informed, activated and collaborated, the outcome was very good. And when the patient was informed, activated and collaborated, the outcome was not good. You are going to see that with information, activation and collaboration, the result is very good. So when we inform our patient, we share with him, activate and collaborate, we are going to get good results, more than bad results. Even with the multidisciplinary approach, the patient, the doctor, the organization, the nurses, the community, we are going to find very good results. Again, or facing 0 bad results, and this is very good. Another trial, another article in the Dow Publishing Group by Dr. Charles Chazot. This doctor has made an extraordinary experience in Cassine in France. His dialysis unit is dialyzing for about from 4 to 8 hours, and his mortality records is 50% less than the United States of America. In spite, America is the highest country in the world on the cost of the hemodialysis. He did this by applying what is known as patient-centered medical home. What is patient-centered medical home? I'm going to consider my dialysis unit a home for the patient. And my patient, while at home, is going to receive all the service he wants. He is going to be examined by a nephrologist, by a dietitian, a psychologist, a radiologist to examine for the fistula, a vascular surgeon if it needed, and he apply a social worker, and he apply all these criteria for each patient every time. All his patients are examined by all these individuals each session, and they all receive dialysis session from 4 hours to 8 hours. The duration of the session is not fixed for each patient. It's going to change according to the patient needs. And he measured the outcome by the mortality, the cardiovascular, the sodium, potassium, all the markers to say that I'm doing good dialysis, and all his markers are very good. So he published his experience, and he said that the testing center offered the following lessons. Longer dialysis session provide a better blood pressure control, more frequent use of the fistula, better than the catheters. Proactive fistula care reduces the complications, which is the most common complication, by the way, in hemodialysis. Multidisciplinary teams provide better outcomes and more results and more good results to our patient. So he took the idea of the patient-centered approach, and he applied this patient-centered approach in his dialysis unit. All these teams, the nephrologist, the dietitian, the social worker, are serving the patient regularly. So he got a very good result. What about the opinion of the doctors? They are another side of the equation. We are the providers of the service. They have done this survey involving about 34 healthcare professionals, 16 from the geriatric department, 15 from the surgical intensive care, and 3 quality employees. The 34 doctors didn't approve for the 8 steps we have mentioned, but they say that there are 3 main viewpoints from the healthcare point of view. These 3 points are treating patients with dignity, the interdisciplinary approach, and the equal access and good outcomes. Again, the doctor is looking to the outcome, but he agreed to treating the patient with dignity and respect, the interdisciplinary approach, equal access and good outcomes. Closing, the patient and family-centered approach is working together, not working for someone. We are not going to do, I'm not going to do something for you. We are going to do, all of us, for us. The values and value of patient-centered care, when we are talking and we are dealing with our patient, please don't be sharp. And please don't end your sentence with, you have 1, 2, 3, 4, any questions? You are good? Okay, Assalamu alaikum. This is not acceptable. Please, after explaining your disease, your point of view to your patient, sit with him and tell him, this is your disease, these are the complications. I know you should have time to understand and to comprehend. Do you have any questions? We should ask our patients, do you have any questions? Can you summarize to me what I have told you now, so that I can get what is in his mind, and then I'm going to deal with him. The misconceptions, the patient family-centered care is not just being nice, just smiling and not going to be nice, no. And it doesn't mean to give up all the decision-making to the patient and to the families. This is not going to be practicing medicine. And it doesn't mean at all there is no boundaries, there is boundaries. And it doesn't mean at all that the patients and their families should be rude or abusive. There are boundaries, we should be polite. We are the decision makers. We tell them what's right and what's wrong. And again, it's something I think it needs a very long talk with the relatives and with the patient himself. The hospitals and the health systems must create a variety of ways to get the patients and the families to serve. We should attract our patients and their families to serve in our system. How can we do this? By making working groups, peer support, members of committees, patients as educators. They should stand in here instead of me, and they should talk about their vision to improve the service applied for them. Speakers on panels and review brochures and education materials. Again, we should put our patients in our hearts, not just in our prayers. In conclusion, Einstein defined the word insanity to keep doing the same thing and expecting to have the same results. We have been, for centuries, practicing medicine in a disease-oriented manner. And I think it's time to change and to practice it from the patient-centered manner. And thank you.
Any questions? Any questions? Yes. Please, Mike, you want to just a comment here?
Okay, thank you, Dr. Ahmed, for your presentation. And now it's open for discussion.
It's just a comment I want to make. Thank you so much for the presentation. It was very, very nice. And I think it's one of the presentations that I personally appreciated very much. I say this because I think we may have a problem as doctors. We may have a problem. I was getting a little bit depressed when I think about my patients and how much I have to do for them and what they cannot afford to do. Now, listening to you speak about shift to patient-centeredness as the patients approach death, I think it's excellent. It's something that I've maybe neglected. In wanting to focus on every individual comorbidity that is in the patient who is dying, I think I may have neglected that aspect of centering on the patient himself. So I think I've appreciated the fact that as the patient starts getting from step 3 and down here, we now we focus on the disease and try to change some of these aspects. But as the patients are they go towards their death, I think we need to focus on what is their need. And I think that was very good.
Thank you.
I just want to add a comment regarding patient-centeredness approach or patient-centered care is not that the patient will control the medical aspects. The doctor is a controller. There should be professional integrity. But when you incorporate the patient within his care, he will trust you and he will help the process of medical service. But at the end of the day, a good doctor is responsible about this, because a good doctor treats disease and a great doctor treats patients with the disease. So we should know that, because sometimes you can find doctor in some countries with high medical legal aspects saying to the patient by non-professional at all, and instead of applying the needed principles of patient-centered care, he conducts what's meant protective medicine. Protective medicine means that I come here for a couple of months or years to take money and live well. So I take care of papers, I take care of documents, and if there is an invasive maneuver that should be done, I move snaky and then telling the patient many complications to allow the patient to refuse the treatment. And then I allow him to sign and print that he refused. And then I say he is refused against medical advice. Okay. So,
regarding what?
yes. Dr. Ahmed?
Thank you for this very interesting thing. I want to ask about the boundaries between the patient and the doctor.
You are asking about something very easy. The boundaries are put by the doctor and by the patient. There are some boundaries, like Dr. Hussein said, the medical boundaries. In one of the papers I have showed you, we have set an example for such boundary. You can make a patient go out from your clinic and he is very happy with you as a doctor because he asked you to prescribe some antibiotic for him. You as a doctor do not agree to prescribe this. It's not suitable for his case. But you prescribed the antibiotic to satisfy your patient. This is patient-centered approach. You have satisfied your patient. You have approached it. You have achieved one of the goals. You have prescribed antibiotics and your patient is now satisfied. Okay, in medicine practice, this is wrong. So, putting the boundaries is not crossing you are not going to cross the lines. The final decision, the final medical decision is going to be made by you. And by here I mean, you are not going to tell your patient that his conservative treatment is sufficient while he needs to do dialysis. You are going to tell him that his conservative treatment is not sufficient now, and he needs to start dialysis at this time. If he refuses to do dialysis, this is his choice. You are not going to obligate him to do this. But the boundaries here is, you cannot tell him that dialysis is not important for him. You should tell him that the dialysis is important, and then let him choose. If he chooses, or if he hadn't chosen to start the dialysis, you are going to tell him the modalities. You are going to tell him that this one is good for you, this one is not good for you. He is going to take the bad one. No. This is your decision, not his decision. You are going to explain what is right and what is wrong.
Excuse me, this is like the boundaries between wife and husband. So, the wife here in Egypt, this is our culture, that the wife makes her husband feeling that he is controller of everything. But at the end of the day, he obeyed all her orders. So she is a big boss here. So we should be professional. We should keep the boundaries with the patient. It is very bad to be sympathetic. So that if the patient comes with comorbidities, then instead of helping him, you weep. This is not doctor. And at the same moment, you shouldn't joke with the patient. You should be a nice person, but not jokey person. So the boundaries is important. And I have my own statement that I educate medical students regarding dealing with the patient with history and examination. That clinical examination is a bidirectional process. This means when the patient enters the room for interview, he looked at you. In the same moment, you look at his eye or her eyes and saying this is proptosis and exophthalmos, he says this is good doctor or bad doctor. Because when he looked at you, he found you joking and staying with nurse or third partners, and everything is bad besides you. When he looked at this scenario or this environment in in femtosecond, he knows that this doctor is not professional. And from the beginning, you lost his trust. So be careful about the appearance and the setting. As Dr. Ahmed said today, and Dr. Ahmed Kamal said yesterday, the setting of interview and the conducting interviews is very crucial. So be nice, but everything, if done in extreme, it loses its function. So again and again, in one word, professional and the professional integrity. And when I speak to the patient, as Dr. Ahmed mentioned, we have 3 alternatives management. The best from the medical aspects is so and so and so and so and so and so and so. And the side effects of this or the cons are so and so and so. But from my preference, this is better. And then, if there any alternative doctor, yes, there is so, but the problem is so, and the advantage is so. Sometimes you know the alternatives. For example, in treating immune-associated kidney disease, we know that the patient needs renal replacement therapy, transplantation, hemodialysis, peritoneal dialysis, hemodialysis. All these are different modalities. But if you don't have except hemodialysis, you are left with no alternatives. Okay? So you tell the patient real alternatives and not to go through this space. Be realistic and simple, nice, and by these ways you will achieve and be accepted from the patient, and he will trust you, and what you say to him, he will follow. This is the patient-centered approach. Let the patient to decide what you would like to decide. This is your job. But if you say to him, this is good, but if you, this is another good, so by this way he become sure that you are not professional. Is there any questions? Ahmed? The concept is clear. Like wife and husband. Don't forget.